I'm Dr. Jayesh Bhaviskar, and I'll be speaking for total hip arthroplasty in a fracture neck femur in Parkinsonism. Now, this patient was actually walking unaided before the surgery, so which means that the severity of the disease is not very significant. So what we know right now is a total hip replacement is the gold standard against which we have to now compare whatever new modality we are planning to do. So ceramic or metal on highly crossing poly with a large head has shown more than 80% long-term survivorship. The dislocation rate is around 2 to 16%. It is higher in literature in a total hip replacement done for a fracture neck femur. The reasons given are posterolateral approach and a small head size. Now we already know that the approach is not the main culprit in dislocation. It is more of during the malposition of the implants. And smaller head size, now you can actually increase your head size with the newer polys. Earlier we did not have highly crossing polys. Nowadays with highly crossing polys, you can use larger head to improve the stability. Also with use of larger heads, we can, and increasing the head neck ratio, we can increase the mobility as well as the stability of the implant. So if in literature now there is when it was compared as to the older generation, that is small head total hip replacement, dual mobility and a large hip total hip replacement. The dual mobility and large head were definitely better in terms of dislocation rates as compared to a standard total hip replacement. Dual mobility slightly outscored the large head, but the results were almost equivalent in them. So we know that this slide is always put up that the large head has a higher jump distance and therefore it prevents dislocation. But is dual mobility an answer to all the problems which occur? No, that's not. There are a lot of complications which are still there. The most important one is the interprosthetic dislocation, in which there is a dissociation between the inner metal or ceramic head and the outer poly. This can happen at various stages. One is during the reduction. If you have a difficult reduction, then there can be dissociation during the surgery, or later on, especially with earlier generation implants and smaller head size, that is 22.2 mm head size, and earlier poly in which the capture mechanism used to give way and therefore you had interprosthetic dislocation. As already described, edge loading and wear were also an issue with the older generation, in which the metal or the stainless steel cup was used. Now if you look at the component design, there are no areas to put the screw, to put any screws, and you cannot see the posterior edge or the seating of the implant. So this can, in a person who is not regularly used to a dual mobility, can cause malposition of the implants. The cheapest implant available currently in India has these spikes, which were difficult to put in a sclerotic bone. So if you had a normal or a osteoporotic bone, then we could implant these, but in a sclerotic bone, these spikes would not go in and your position was slightly outside, which causes malrotation, which causes decreased osteointegration and could lead to failure. So in the older designs, the cup was a stainless steel cup with an alumina coating. It had poor fixation. There was wear at a retentative limb. The spike seating was not done well in a sclerotic bone, and because of the impaction, if the cup was not seating and you impacted very hard in osteoporotic bones, there was a risk of periprosthetic fractures. To obviate these and to prevent better seating, now we have a newer design in which you have a cup in which you can put screws, then you have a rim liner, then your poly, and then your metal or ceramic head. But history has taught us that the more mobility that you give or the more modularity you have, the more there are modes of failures. And these are newer implants and we don't know yet as to what their long-term results are. Then there are technique and implant related issues. So there can be a shell deformation. If your cup is under-reamed, then when you put a dual mobility, there can be a cup deformation, which can cause malalignment of the cup and liner lock mechanism can fail. There can be a damage to the taper of the liner during insertion and failure of the taper lock mechanism and seating failure of the liner. So in a cadaveric study, Markel tested a press fit technique of acetabular shells and found that compression deformation occurred in all their tests with an average of 0.17 millimeter of pinch deformity, while Escalade reported infromedial portion of the modular dual mobility liner might be mal seated even if the visible portion, superior portion might seem seated.
Can you please wind up?
Yes. So, and Asian hips with a smaller acetabular size have, if you use large head, then the smaller, the small acetabular size and a big head works like a dual mobility by preventing dislocation, which is why a total hip is better than a dual mobility in these patients. Thank you.